place.
And we go to WC.
What's the other thing?
And usually the sun's either down or just
Oh, wait, you don't know that.
but it's pretty tough thing.
All right, here we go.
Well, we have considered it actually.
Yeah, that's right.
All right, we are ready to reconvene.
When you're grandparenting, FaceTime.
All right, apologies to everybody for the short lunch span. I know it's hard to grab a quick lunch and to come back and to be prepared to head right into it, but that's what we'll do. So we're going to move now into the further discussion and voting. And to do that, we just need to make sure that the voting technology is up and running. So I'll invite Ellie back up to help the CEPAC through that first exercise.
So per our usual tradition, we'll do a practice question to see if we're working okay. So our practice question today is, in what year did the Macy's Day Parade begin? So when was the first Macy's Day Parade? So if everyone should see that popping up on their screen.
The time to raise your hand if you're having any technical difficulties.
So I can't type. So once we hit our answer, then what do we do?
Nothing.
Just leave it.
Press submit, or
Just nothing.
no submit? Okay, then I think you should be good.
Scroll back.
And you can change it up until. Yeah, I think we should change it.
Here are the results I'm seeing.
I don't know. I think I am, because I don't know.
Where's your eye? Is it getting better?
It feels better.
15. So I'm missing 3 people's votes. You're one.
So I think this clearly demonstrates chance.
I am biasing this vote, that's true, but we won't do that for next votes. Maybe not.
Yeah, I have it. Just keeps telling me that I need to.
I could re-poll the question. I'm confused about
I'm not.
animation. You're not the expert. All right, Mag is the expert.
I'll stick with 18. Why don't you trade places?
We'll do it one more time.
No, don't have them all vote again to see if we can get the additional votes out.
Okay.
It may just be that I have to refresh it here, but I don't know.
Sorry, I downloaded the app and it keeps telling me I need to update the app. I have updated the app.
So she pushed to see the results, and I think once that happens, then further results.
Yeah.
What do we do?
Right.
We don't want to have a high.
Do we want to try? Oh, we don't?
It's just a rails.
You can't do that.
Okay.
No.
All right, we have to start over.
Yeah.
Okay. Okay, so the other stuff I can't do is if this happens again by accident. There's in the past it hasn't done. Again, it's complicated.
I'm pretty sure you can't, unless Matt has a magic solution, but
We'll have to have another session because Matt, last time, and I pressed it on ahead. It was really quick to get back.
oh, really?
It took like 1 click.
Okay. We'll have that.
Okay. As in most things, there's an alpha version and a beta version, so we're going to have to vote again. Apologies. So go ahead and we're going to wait until we have the full complement of votes to make sure that everybody's is getting recorded. Should be 50.
Oh, really?
Now that you've seen the first pass, you can change your vote.
Oh, you're anchoring
Help from a friend, whatever it takes.
So.
All right, one more. Don?
I said, I'm going with 24.
Okay, now we've got, all right, everybody's in. So now we can see.
Depression.
All right, ooh, there was an interesting shift in the votes.
See, more people see mine.
Yeah, I was told mine was wrong.
All right, so now, yeah, if they Google, you can tell them what it is.
The correct answer is 1935.
I went with the, like,
B.
35. They couldn't afford all that kind of
You think it's 1924?
Next time we're going to...
I think it's 1925 or 35.
All right, so most important part of today's meeting will be, at the end of it, we will actually have the correct answer known, and we will announce it and put it into the record. All right, it's either 24 or 35. Okay, but now we know that everybody's vote is registering. We can move on to the discussion. Now, I do want to save time, adequate time for the policy roundtable, but we don't want to give short shrift, obviously, to the discussion around the votes. So we're all going to have to try to be very efficient. If you do have a question, please put up your name tent card, and we will try to go as rapidly as possible, but I'll try to watch the clock, and at certain points, I'll try to get a gestalt about whether we've had enough discussion to move forward for a vote. All right, so, and again, up here for your benefit, we have clinical experts, we have the patient representative, and we have the ICER and University of Colorado research team. So with that, our first voting question will be, for patients greater than or equal to 12 years old with uncontrolled moderate to severe asthma and eosinophilic phenotype, is the evidence adequate to demonstrate that the net health benefit of dupilumab is superior to that provided by standard of care, which is steroids? I keep getting the wrong acronym in there too. So steroids plus at least one additional controller medication. Now, as we do, Jeff, I'll just quickly turn back to you to comment on where in the evidence summary of tables from the report the CEPAC can find the key information that you think pertains to this voting question.
Right. So I would focus your attention probably on tables 4, 5, and 6, remembering that tables 4 and 5, there's a significant amount of heterogeneity between the populations studied. And so those improvements in quality of life and the reductions in exacerbation rates may not be comparable in those tables 4 and 5 because the populations are quite different. In table 6, we attempted to have a more homogeneous population. It's not perfect, but it gives you a better sense. And in particular for dupilumab, since we're focusing on that, in tables 4 and 5, those numbers reflect the overall results of the clinical trial. And the FDA indication is actually for eosinophilic asthma, so would exclude those with lower eosinophil counts that were included in the trial. So the results from table 6 may be more appropriate, though our colleague from Sanofi Regeneron suggested that the indication suggests that it should be 150 or above, so greater than 300, you get a better relative effect than greater than 150. Greater than 150, I think it was about 0.44. The rate ratio versus 0.26 in the greater than 300, 0.52 in the all comers in the trial. So sorry to go on about that, but 4, 5, and 6 is a little bit more comparable. And then the key finding is that there were no significant differences between any of the agents in our network meta-analysis, nor in almost all of the network meta-analyses that are in table Appendix B, the number that have been published so far.
Okay, Jeff, and if you can briefly summarize, we're focusing on dupilumab this time versus
right. So that's
standard
why
of care, and can you remind people of the rationale and the ICER evidence rating?
So the ICER evidence rating for the two agents that have been around the longest, omalizumab and mepolizumab, are Bs, so small net benefit, high certainty, with Dr. Wiltz dissenting from that, as you heard earlier. And for the other three agents, in part because of greater uncertainty, C pluses, so comparable or better. So greater uncertainty for reslizumab, benralizumab, and dupilumab here being the focus of the question.
Okay, and the uncertainty being localized to the fact that they haven't been in practice as long? Is there any other kind of
primarily,
uncertainty?
and relatively small numbers, one trial.
Okay, all right. Tim, we're welcome to come back to your questions because this is the time when the whole panel should wrestle with the weight of the net. When we talk about net health benefit, it involves obviously the benefits, but also some consideration or full consideration around the risks as well. So you had raised some questions that kind of in your mind, you did not think that the standard of evidence here was adequate to demonstrate a net health benefit. Would you like to revisit that?
Thank you, yes. I might tip off what I'm voting, but can I do that?
Oh, yeah, sure.
Okay. I'm going to vote no on this, and here is my reason. I've looked at the D studies, and the average difference in health-related quality of life did not achieve minimally important difference. The 95% confidence intervals around those scale scores did not achieve a noticeable difference. That means at least 95% of individuals do not notice a difference in the main outcome of quality of life. They do not see a difference in the main measure that we have on assessing does it improve the outcome that's most important to them. With regards to exacerbations, there's no data on hospitalizations or rate of ER visits. So the only data we have on that, as best I can tell, is the use of oral corticosteroids, which I think is an important outcome, but that absolute difference is less than 1%. So we're now looking at somewhere around 1 to 200, 1 to 300 number needed to treat with that. Let's see, what was the other thing that I wanted with regard to that? Most of the studies don't report on reduction in oral corticosteroid use. There is one study that did. I believe that was probably in people who were on oral corticosteroids. There's a reduction. I don't think, given that the harms that are associated with it, the lack of clinical benefit and the main outcomes, the minimal benefit on the exacerbation only is defined by use of steroids, and then the cost associated with it. I know we've looked at the cost analysis. That's from a societal perspective, but I think from a patient perspective, that is part of the burden and cost that they have to achieve, and so I consider that part of the harm in my balance of benefits and harms.
Okay, quick reaction from Jeff.
So just one, I should say, in the clinical trials, and I didn't emphasize this at all, the primary outcome was a reduction in exacerbation rates. The absolute numbers are low, and I certainly appreciate that analysis, but at least from the FDA perspective, it was exacerbations as the primary. We've talked about quality of life because particularly for the long-term estimates of value, it's quality of life that's more important than exacerbations. But we also heard how important exacerbations are to patients, so I don't want to undersell that.
All right.
I just want to follow up on what I said. The two individuals particular who presented, they provided very powerful stories, and I think I have little doubt that they were responders and that they have achieved a benefit. I'm working on the data that we have from the evidence that's presented to us.
Let me invite the clinical experts to comment on, in particular, the framing of what % of patients notice a clinical benefit, a clinically meaningful benefit. Do you agree with that characterization? Not from your own clinical kind of practice experience, but looking at the evidence. Do you think there's a different perspective that the council should consider?
So I stress Dr. Tice's views that table that reports for dupilumab in the overall intent to treat population, the rate ratio was 0.52. When you look at this question, which is the eosinophilic patients, then the rate ratio is even lower. It's around 68% reduction in exacerbations. So to address your comment, the quality of life measure that is reported here in the report is a mean difference compared to placebo. The person that developed this instrument, Liz Juniper, never intended for it to be reported this way. She reported it as what proportion of patients met the MID, the minimally important difference, and that a proportional comparison should be the way you interpret this, not mean differences between two groups. And so when you look at the data, about 2/3 of patients met the MID in this group. But again, this instrument is, whenever you give an injection or an infusion, patients have a huge placebo effect. And so when you report the difference compared to placebo, that's when you see small differences. So again, just based on the data, I would say that about 2/3 of patients have a meaningful improvement in their quality of life based on the data.
Tim, do you want to react to that?
I guess it would just, I don't see where the 2/3 are. There very well may be a large placebo effect that I think is part of the problems with N=1 studies. If a drug has potential, I think N=1 studies are useful if an intervention is cheap, safe, and can avoid more serious, more costly effects downstream. In that, however, I think what we're asked to do is look at what it is compared to usual care or placebo. And in this case, what we see again is the mean effect on the quality of life scales. Admittedly, there may be problems, but I don't know what else we have because the other data are either not there or this is what's generally been wisely thought of. And that the 95% confidence intervals demonstrate that there's still not a noticeable difference for the vast majority of individuals. So there's data on how to report that. If the mean effect, the average effect falls below the MID, but the confidence intervals overlap the MID, you can say things like most would have, many might have, or in this case, because they don't even achieve that, it's probably going to be the large majority would not have. Alternatively, the pharmaceutical companies can provide you the data of the percentage of individuals who achieved, in this case, a 0.5 MID in the placebo and the drug group, and then we can look to see what that is. And then we as a group can decide, I'm just making this up, is a 40% versus a 30% who achieves that, is that something that we know? I encourage the companies to provide us that data. I bet it'd be probably pretty small given what the confidence intervals are.
All right, let me circle back to, Jeff for one more, come back on that, and then we'll open it up to other questions.
I wanted to still come back to the exacerbation rate, sorry.
Go ahead.
So the average exacerbation rate in the placebo arm in like the dupilumab trial was 1 per patient year, not 1 per 100 patient years. So,
No, I know that.
Okay. So the number needed to treat is about 1, not 100, or 2.
That was the
Yeah, 2.
That was the exacerbation rate. I think the differences were somewhere less than 1% annually.
No, you went from 1 per person year to 0.3 per person years in the dupilumab trial. So that's a 0.7. So 1 over 0.7 is a little less than 2. So if you round up, it's 2 patients treated to prevent 1 exacerbation.
I'll go back and look at that. I mean, it didn't come across as that way.
Put up your tent, but I see Albert's hand. Go ahead.
Yeah, so when I'm gonna vote on this, I'm looking at not only the quality of life measure. Can you hear me?
Yeah.
I'm gonna look at the quality of life measure, given all of its warts, but I'm looking at the relative risk reduction in events, which I mean it looks substantial to me. And then I'm going to look at the reduction in the use of oral corticosteroids. It's like 50% reduction in some of these trials. So, I mean, you're off drugs. So I'm going to view all that as net health benefit. And also, there's a report on the adverse events in one of the slides in 20. And Dr. Tice, if you want to comment, you evaluated severe adverse events in the trials, I assume.
Okay. Other perspectives or questions from the CEPAC? It's your time. You have questions of Jeff. You can ask clinical experts, the patient. Does anybody else want to kind of foreshadow their vote and share their thinking in a way that would add further light to this kind of consideration? Ryan.
So a question, I guess, for the clinicians. For this phenotype, how much of the environment impacts that phenotype of asthma? So if you are living in very substandard housing, if you live in a community with very poor air quality, is there a relationship between this phenotype and environmental factors?
I can answer that. Certainly, I mean, sorry. There's a big effect on environmental factor that's associated with the worsening of the control of the asthma as well too. So there's a lot of body of the effect on the environmental factor triggers, allergens and things like that that affect the outcome of the patients too. Now it's not really captured in a randomized control, design studies because that's how we do the study too. But it's definitely one of that. And I think one of the potential reason for the placebo effect and all that is that they might control it better in the setting of the study as well too. That we see as placebo effect as well too. But that's the environmental or housing, the issue with the disparity and all that. I mean, those are there. It's a different topic here for that, but that's one of the other aspect of asthma, better asthma care that be focusing on, for years as well too. So it's definitely there.
So can I follow up on that?
What was your question? So was it that the environment can potentially eliminate the positive impacts seen here, or?
Well, one, I wanted just to know, does this phenotype, is it impacted by these environmental factors? And then going down a path of then, I'm assuming these studies did not control for income, race.
Sure.
And so it's very difficult to know when we already have asthma rates 5 times higher in poor kids. Some of what we're seeing here, is it related to class and race and income?
Oh, I see. So, yes, I mean, all these things drive morbidity in this disease and unfortunately mortality as well. And randomization does take care of that, and that unfortunately some of my patients that participate here in St. Louis can get placebo, and they have those same environmental factors. I mean, the only thing I can tell you is that for patients that have received this clinically that come from very poor neighborhoods here in St. Louis with all these environmental factors, what happens is you control that eosinophilic inflammation and their airways are completely reset. So if they tell me, well, before, I think as some of our patients mentioned in the panel, they couldn't leave their homes, right? Because they would encounter these things in the environment, even though some of those things are indoors as well. And now they can leave normal lives because that inflammation is decreased and controlled for the first time. And now when they encounter those environmental triggers, they no longer have that full-blown exacerbation that they did before. So the environment is definitely a big contributor here to morbidity from this disease. And fortunately, this treatment does help impact that.
And I'll save the rest of this for the policy roundtable, I promise. But I would ask then, based on what you just said, would money be better spent on addressing environmental factors and social determinants of health than spending this amount of money on pharmaceuticals?
Hold that thought. We won't be out by dinner. We'll hold that for the policy roundtable because I understand, and it's I think a very interesting question to comment on. Dr. Cimino,
I just want to make one comment because there's in a little bit unique with, well, not really unique, but for the recent study in this particular drug, there's the lung function improvement. We haven't really talked about the lung function there because we talk about the exacerbation and the quality of life measurements. But on the study that's been looked at here too, is that there was significant effect on the FEV1 with this medication as well too, which in the treatment arm about 0.5 liter improvement versus the placebo is about 0.2 and about 200, 300 cc, which is for, again, for severe asthmatics, that is a substantial, actually it's a big effect for that as well, just wanted to mention that. Because that's actually objective measurement versus some of the QOL measurements is very subjective as well.
Kenny, okay, so let me just ask Kenny real quickly. Sorry, I'll try hard not to keep saying that, but you know what I mean.
Right.
Because we've been talking about the net health benefit and the issue of being on oral steroids and kind of these exacerbations. From the patient perspective, is there anything else that you would want to add to the discussion before the vote?
And I think you saw it here in terms of what the patient voices, where these things do work, and they have a, you know, if you're on steroids for a long time, it puts you out of work. I mean, it's terrible for your quality of life. So I think that's really important to keep in mind here.
Okay, thanks. Tim, go ahead.
Just real quickly, I wanted to get back to what Jeff said. So I was wrong when I said about the number needed to treat at 300. I think your comment is correct, that this are annual rates. I just want to read, though, from their executive summary. The reduction in exacerbation rates is often the focus of clinical trials, but patients only have 1 or 2 exacerbations per year. The quality of life when they're not having exacerbations is more important to patients and to long-term value of the therapy. So again, I want to get back to the prioritization of that and what we saw in the mean effect. And when it comes to oral corticosteroids, I agree. I think that's an important outcome. We don't have much data on that for this drug. It's only provided for the one single study in those who are glucocorticoid dependent severe asthma. I think if we're going to carve out a recommendation on this, the evidence would suggest that we try and carve it out on that separate from those other studies, because we don't have information on the role of it in those other patients.
Okay, well, just a quick rejoinder. As with all of our votes, we know that this represents a spectrum of severity of illness, and we're asked to make to make a judgment around the population as it's stipulated, which will include patients who have more and less severe requirements for steroids, et cetera. And I think, did you need to respond back on that? Or if not, I'll move forward towards a vote. No?
Do you want a health outcomes perspective on net benefit?
Under 15 seconds, I do.
I'd just like to comment that one definition of net benefit that we attempt in health outcomes research is the quality adjusted life year. Just to recall from the numbers from the model, it's about 1.5 additional quality adjusted life years for dupilumab versus standard of care alone.
Okay. A great discussion. Lots of issues, but I think we should go ahead and vote. No other tents being up. So please complete your vote. Remember, A is yes, there is evidence that is adequate to demonstrate the net health benefit of dupilumab is superior to that of usual care. We're waiting for one more. Yep, okay. 12 yes and 3 no. All right. I think given the richness of the discussion before the vote happened, which was excellent, I'm going to not go into a kind of a post-mortem and ask people to resuscitate their rationale. 12 yes, 3 no. The next question asks us a very different kind of paradigm of a question about evidence. For the same group, though, patients greater than or equal to 12 who have uncontrolled severe asthma and eosinophilic phenotype, is the evidence adequate to distinguish the net health benefit among the 3 treatment options, mepolizumab, reslizumab, and benralizumab? Jeff, you're up again to steer us towards what's in the report.
So again, I should have said the first time that I don't think the harms are similar for all of these agents, and I don't think they are a major distinguishing characteristic, though there are harms clearly, which is why they're administered in physicians' offices. I would focus on tables 4, 5, and 6 again. Again, 4 and 5 you should take with a grain of salt because of the differences in the population. 6 attempts to level the playing field somewhat, though it's imperfect, but it gives you a better sense. And again, the differences between any of these agents were not statistically significant using our typical measures.
Any questions from and it was an I for the evidence rating?
That's correct. This is an I
Yeah.
for the evidence rating. Insufficient evidence.
Okay. Any questions from the council on this? Oh, sorry, Rachel, yes.
It's not a question, it's more of a comment. And as a professor, I know it's terrible when people say that, but I wanted to say that I'm likely to vote no here, and I think it's unfortunate that we don't have these data. So we heard several of the manufacturer representatives emphasize the importance of choice and how it's important to have patients and their physicians making decisions about which biologics are right for which patients. But we've also heard that many, at least providers, do not feel that they have the information they need to make those choices. And it would be nice if there were to be further development of information allowing them to compare these, but it doesn't seem like any is forthcoming in the near future.
A topic to which we will return in the policy roundtable, for sure. All right, I think it would be good, since I'm not seeing, I think we've heard the evidence behind this, unless, okay, so why don't we go ahead and vote? All right. 13, I'm sorry, I thought we had 15 and it went away. Well, it's either going to be 13-2 or 14-1. So I think we will.
I can't get my screens now.
Oh, is that what happened? Okay, I thought it was in. Well, if you want, you can either tell us your vote offline or you can just tell it through the microphone. It's up to you. But I tell you what, while we're working on the technology, Albert, do you just want to say what your vote was? Would your vote have been yes or no? Or do you want to keep it confidential?
I'm very public. No.
All right, 14 no and 1 yes. If we have 30 seconds, one person voted that the evidence was adequate to distinguish. Every once in a while, I just want to check to make sure that wasn't an accidental vote. Anybody who did vote yes because they thought the evidence was adequate to distinguish? Somebody did. All right. We'll move forward. It's not going to change the history of the world if it's 14 or 15 nothing to 14-1. Okay. The next question. So now that you've said no as a majority to that previous question, the following question in logic is now for the same patient phenotype and age group, et cetera. If the answer was no, so you can't distinguish between the three, MEPA, Resla, and Benra, is the evidence adequate to distinguish the net health benefit between dupilumab and those three treatments? Jeff?
Yeah, so again, dupilumab carries, even though the pivotal trial included patients without eosinophilic asthma, the analysis showed a much larger effect size in those with eosinophilic asthma, so the FDA indication is the same for dupilumab as for the other three agents. And so for exacerbation rates, probably table 6 is more relevant than table 4, but you may want to look at table 4 as well. And then table 5 for the quality of life doesn't incorporate actually the subgroup of eosinophilic asthma. There's some difference. It depends on where you put your cutoff for eosinophilic asthma. If you use 150, the effect size is a little lower than for dupilumab than what we have in table 6. That's for a cutoff of 300, which was the cutoff in for two of the agents. I think it's reslizumab has a cutoff of 400. So they all have slightly different definitions of what is eosinophilic asthma, though the FDA did not specify that in its indication for any of the 4 drugs. So sorry, it's clear as mud. And I guess the other thing, even giving dupilumab a little, the benefit of the doubt that you use a cut point of 300 as the definition of eosinophilic asthma, that's what we used in table 6. Again, no significant differences between either dose of dupilumab and the other agents in terms of at least exacerbation reductions. Well, I should say for our network meta-analysis, we didn't have sufficient data to look at quality of life measures.
Eric?
So we may deal with this on question 5, which has to do with potential other benefits and disadvantages, but mode of delivery or the option essentially to administer this at home, can I consider that in my calculus regarding net benefit as it may improve access and or adherence, or is that?
It's cleaner to keep it as part of the
Okay, just wanted to clarify. Thank you.
Yes, please.
Just a comment. So the only one of the biologics that have an FDA-approved indication right now is dupilumab. So it not only is indicated in eosinophilic asthma, but it is indicated in oral corticosteroid-dependent asthma. So I do want to just bring that up because it is, the evidence was strong enough for the FDA to agree to add that to the label itself.
I missed the beginning. What was the key difference you wanted to highlight regarding the FDA labeling on this?
That it has a separate indication for chronic oral corticosteroid-dependent asthma.
Got it. Okay, thank you.
Yeah.
Jeff, any perspective?
Yeah, no, I agree 100%. It's the only one with an FDA indication. Several of the other agents did study that and had fairly comparable effect sizes. I don't know whether they didn't go for an indication or the FDA turned them down, so I can't comment on that, but yeah.
But wouldn't the working, go ahead. I would say, wouldn't the working definition or one of the ways that we define severe asthma also include possibly chronic oral corticosteroid use?
So just to understand, some of the patients with chronic oral corticosteroids will also fit
Yeah, right. Yeah.
the definition. We put this question this way so that all the drugs would have the indication for what was being asked. This isn't to imply that dupilumab might not also be useful in its other indication in non-eosinophilic chronic oral corticosteroids. This was to specifically ask, among the drugs that all have this eosinophilic indication, can use it.
Right.
I
Raina?
have a question, I'm sorry, clarification. So does that mean that there's some...
Sorry, can you grab the mic? We can't
Oh, I'm
hear
so
you.
sorry. Does that mean that there's some clinical misclassification between these patient populations that we should be considering?
I'm not sure I totally understood. How do you mean the misclassification?
So, I mean, this drug is indicated for both this phenotype and a more general phenotype, correct?
Right. Dupilumab was studied in people without this phenotype, and the FDA looking at those data, it studied also in people without this phenotype, and the FDA looking at those data concluded that it worked in those patients without this phenotype who were on chronic oral corticosteroids.
So my question is in real life clinical practice, can clinicians not necessarily distinguish between people with this phenotype and the more general phenotype?
Sure. We can. I mean, we use the CBC and we look at their eosinophil count, and so we can identify these as a eosinophilic phenotype based on their blood work.
And that's routine in clinical practice that you would go ahead and do that?
Yes, it's routine clinical practice. And again, not speaking for why the FDA put this on the label, but at least the data, as Jeff Tice presented nicely, was the intent to treat population took all comers, eosinophilic and non-eosinophilic, showed an effect. But when you looked at the subset that had greater than 300 absolute eosinophil counts, the effect was even greater. And therefore, that came across in the label.
Okay, Tim, go ahead.
Thanks. This is useful. So I'm trying to, that eosinophil count, that's been derived before all these studies start. I mean, it's just somehow this 300 number comes up, and I'm just trying to figure out where the 300 comes up. You know, what about 299? What about 301? It reeks of post hocness, but maybe not, and maybe that's how they enrolled them. Maybe they got them in. And then I'm trying to look at the results, and I really am trying to see if there's a differential between this drug and the others. So this drug, the D drug, specifically enrolled people with that condition and studied it uniquely.
So you're talking about dupilumab?
Yeah, the D drug.
No. So in the pivotal trial, they took all comers with moderate to severe asthma and randomized them to dupilumab or not.
Yeah.
There was, so I want to step back partly to address your preamble. For some of the other drugs, there was early work that suggested they didn't work very well in patients with low eosinophil counts. And eosinophil counts are a marker of more type 2-ness in the asthma phenotype. So I think some early studies looked at that, and then many of the trials, though, the pivotal trials for the other agents used a cutoff of 300, and in one case 400 for entry into the trial. So it was pre-specified, that threshold for the other agents. It was not for dupilumab, though they had pre-specified subgroup analyses looking at that because of the a priori knowledge that in general, it's an effect modifier for agents, including even omalizumab, which doesn't target eosinophils directly. The omalizumab works better with higher eosinophil counts as well.
And so is it a true effect modifier, or is there has been, I think, suggested that just the risk ratios are a little different?
Well, that's what effect modifier. So the p-value for interaction, the p-value for interaction was significant for all of these. So yes, it's a true effect modifier within the uncertainties that are acceptable in medical statistics.
And then that table 6 you're referring to, is that the subgroup results, NMA, EOs greater than 300, greater than 2 exacerbations?
Yes.
And so we should be looking at those, at least for exacerbations, for that one. And is there a QOL slide as well?
There's not. Unfortunately, we had insufficient data to do
so we
quality of life.
need to either base it on that or this slide here. Okay, thank you. That's helpful.
Okay. I am going to go ahead and invite people to start their voting. A is yes, there is adequate evidence to distinguish among them. B is no, there's not. Okay, 15 no, 0 yes. Let's move on for time to one last clinical effectiveness question before we do other benefits and context. This one, same patient subgroup, if you will. Is the evidence adequate to distinguish the net health benefit between omalizumab and these 3 treatments, the MEPO, Resla, and Benra, which you earlier said could not be distinguished in their net clinical benefits? So omalizumab versus them in this patient population. Jeff.
All right, so I'm just, so this is specifically in the eosinophilic. So omalizumab, remember, its FDA indication is really for allergic asthma, not for eosinophilic asthma. However, within several of the trials, they did an analysis greater than 300, less than 300, and showed a significant interaction. And you saw that in the slide. It showed that the rate ratio for omalizumab overall compared to omalizumab in the greater than 300, there was a greater reduction in exacerbation rates in our analysis. So you can, again, for exacerbation rates, you can look at our table 6, which is the network meta-analysis, and get some sense of the relative differences in reduction in exacerbation rates. None of them were significant. The credibility interval, sorry. For these Bayesian analyses, you don't use confidence intervals. I want to make sure I get that right. Did not include one, but effectively it's very, very similar concept. So no significant differences.
Okay, we may have ironed out the questions around the patient group and how it relates. Any questions about this particular vote? Eric, you look unhappy. That's okay, you can be unhappy. I just wanted to make sure you had a question. All right, we've got other, oh no, I get it.
So my unhappiness comes from, it's not unhappiness, that's the wrong term. So it has to do with certainty, right, in the fact that there is a lot more experience with one of these medications over the others. And that duration of experience over a significantly longer period of time should provide a higher level of confidence in the estimates that we have regarding the effect in terms of asthma exacerbations, OCS use, and or quality of life. And so that's in my brain as I think about this particular vote. But when I look at the evidence that's presented in front of me, it seems that the duration of it seems that the amount of time that the product has been on the market hasn't translated into clear evidence in front of me today. Is that a fair, I'm asked that to Jeff, like, have I understood this the right way today?
So I think the one area where you have more certainty from the long-term evidence is of the fact that there aren't going to be unexpected harms from this therapy.
The safety profile.
The safety profile,
Okay.
I think, is more certain. I open it up to the experts. I may have missed this. I mean, ideally, you would do, you could use observational data with a propensity score weighted sort of analysis to look observationally at whether you see the similar kinds or greater effect size over time with these agents. And I'm not sure whether a high quality observational trial has been, study has been done looking at that with omalizumab, and I look to my experts to see. I didn't see one, but I could have missed it.
I agree with the first comment that the long-term data is really around safety. It's probably been the best explored. There's been large looks at the cancer risk, cardiovascular risk. All those have been well addressed with the FDA and satisfied our safety concerns with this drug. The problem is that the studies that were done 12, 14, 15 years ago, and the whole, how we treated patients has changed over that time period. And so the evidence has not kept up with that. And in essence, so it's not like because it's been out there longer, that there's greater evidence, per se. Thank you.
Okay, let's go ahead and vote on this question, please. Yes, there is evidence that is adequate to distinguish the net health benefit between them, and B is no. Still waiting for one vote. There we go. Thank you. Okay, 15 no and 0 yes. All right, so now we have approximately 20 minutes is really what I'm hoping we can shoot for to do important work, which is to talk and vote about other potential benefits and disadvantages and contextual considerations. So what I'm going to do first is just explain the question set, read a little bit more because the language up there is contracted. The goal here again is to try to address issues around value that are important to a variety of different stakeholders, but which are not well captured in the clinical effectiveness information or the cost effectiveness information, or even if it is, it's something that we want to make sure that policymakers are aware is important in looking at value from a broader perspective. So we're asking in the treatment of these patients greater than 12 years with moderate to severe asthma, we're focusing on one drug here, dupilumab. There will be a chance for you to actually make statements about the other drugs, but in a more qualitative fashion. We decided to vote just on the new kid on the block. So we're asking about, for it versus standard of care without a biologic, does its treatment offer one or more of the following other benefits or disadvantages? And I'm going to read them quickly just because, again, the broader language is somewhat helpful. You're going to vote on all that apply. Dupilumab offers reduced complexity that will significantly improve patient outcomes. That's another benefit that we include that's usually meant to capture easier mechanisms of action than another kind of option, like a pill versus an IV, that kind of thing. B, dupilumab will reduce important health disparities across racial, ethnic, gender, socioeconomic, or regional categories. C, will it significantly reduce caregiver or broader family burden? D, does it offer a novel mechanism of action or approach that will allow successful treatment of many patients for whom other available treatments have failed? E, will it have a significant impact on improving patients' ability to return to work and or their overall productivity? And F, if there's anything else not on that list already that you think is an important benefit or disadvantage that should have an important role in the judgments that people will make about the value of this intervention versus non-biologic care. So with that, let's start to go around and get some comments on what people think And this, again, this is a great opportunity for people to say that they will or won't be thinking about voting for one of these. And again, we can engage with patients, often are the originator of some of our ideas about what these other benefits might be, so we can ask them, or we can just kind of go around the horn. I think first up was Ryan.
I just more so have a question.
Sure.
Can you remind me, for this question, are we supposed to, regardless of price?
Yes.
It's really hard. Okay. Because at the current price in the report, I would answer these questions differently depending on the cost effectiveness.
In our overly precise way, we have tried to segment this away from the question of cost effectiveness as it's measured, again, with cost and the clinical benefits. I understand how that can be hard to completely tease out, but it's meant to capture non-cost related factors. Now, the disparities is a tough one because the cost could lead or diminish disparities in terms of who can afford it, who can get it, where can they get it. So I'll take one step back from what I said before, which is that on disparities, we sometimes do talk about how the cost aspects can have an influence on disparities in outcomes in the country. Okay, so let me run, I'll keep going. Harold? Can you grab a mic if you've got one?
I just thought that the self-administration is a very important aspect, and that was a very legitimate benefit to patients.
We'll bring that out. I tell you what, we'll note that this was supposed to be about dupilumab versus treatments with inhalers, and so it was not about the the IV forms of biologics. But given your comment, I'm going to tag that for basically where we're going later, where we're going to talk about any distinctive benefits of this versus the others, or the others versus it. So, ease of administration could reduce the complexity and lead to improved outcomes for some patients. Rita.
Along the same lines, what do we know about adherence in this therapy relative to usual care in the community setting?
I guess the clinical experts, in lieu of real data, certainly with dupilumab, because it's not been licensed for this use for very long at all, but any sense that you want to give to that aspect?
Sure. So our adherence with biologics in general, I can certainly speak to, has been excellent. It's around 90-95% in our clinical practice. So much so that some argue, because the adherence with other therapy, the standard of care therapy here is often 50 to 60% or less. I mean, in terms of patients space out their inhaled steroids, start taking it every other day, so the standard of care is much less than what we observe with biologics. Steve mentioned that we haven't had this out only for a few weeks in our clinical practice, so I can't tell you what it is in clinical practice, but the adherence was measured in the clinical trials and was extremely high. There was only a 2% discontinuation rate of the therapy in the clinical trials.
I think in my population, it's probably a little bit less sophisticated than Dr. Castro. So I wouldn't say 99%, but it's still pretty high. I think it's also with the fact that we do talk about the commitment beforehand as well, about the injections before we start as well, because I know it's maybe coming up in the discussion later, but of course it does require a commitment from the patient to come in every 2 weeks or every month to get this injection. So of course, if they don't want to do it to begin with, that's not really the option too. So there's a selection that happens there as well too. But I think in my more older sort of VA population, it's still probably up in the 90s.
So so you're talking generally about these drugs, not this one specifically, correct?
Sorry. Oh, yeah, yes. I thought, sorry, 90% for the biologics when, for the injections. Now, for the usual inhalers, like Dr. Castro said, it's anywhere from, 50% to 100%. But I think for severe asthma, it's probably higher than 50% in general, probably like 70 to 100%. It depends.
I'm sorry, but this is a drug that's actually self-administered in the home. It's not in the clinic, correct? So should we
I think it's a little bit difficult to talk about this drug for the adherence for this one because it just came out in the market. So I don't think we have a real life data for what the adherence will be, is going to be for this.
But the clinical trials that we did with it were using this scenario of the patients doing it at home in the clinical trial.
So we should expect that the adherence is going to be similar to what we expect for other at-home administered drugs.
Correct.
Correct. Thank you.
All right, we'll try to keep going relatively quickly. Tim?
I look at this differently if I break it out by moderate versus severe. And I think there's important clinical implications because the definition, both in terms of the total population, which is likely to be much larger if we define it as moderate versus a smaller group of severe, and the likelihood of a potential net benefit is likely to be greater in severe than moderate because for moderate is defined as control with low dose inhaled corticosteroids or a LABA. That to me sounds like, pretty reasonable management of patients that whereas severe asthma that requires oral corticosteroids greater than 50% of the year or a combination of high dose ICS or LABA. And the studies of DUPA, I'm just never going to get it right, so whatever. Enroll people with moderate to severe, but I don't know if they reported outcomes separately by the classification of moderate versus severe.
Okay.
But when I look at
Tim, just to clarify, again, this is not talking anymore about clinical outcomes. These are about
I know, but I don't
features,
know if,
and they may still be more pronounced in severe patients. But we are asking you to consider the population as it's labeled and to make your own best judgment of how these will play out over the breadth of that spectrum of illness.
I just think it's hard when it's lumped together.
It is. It is. All right. There were other tents up. Aaron.
So I just maybe I'm missing something, but the only studies of this drug were in addition to usual care.
Correct.
So how is it possible that it could reduce complexity given that?
It can't.
Okay. Good.
I tried to make
Can I just?
Yes.
Can I just give the patient perspective here? Because some of these drugs will work for some patients, and some of them will not work for some patients. I mean, it just depends on your, your DNA. I would say that the most important thing is that they work, and if they work, no matter which one it is, I think that all your questions here will come out, as valuable to the patients. So that's one thing I just want to say.
Okay. Yes.
Quick addition to that. So I would say if I'm on chronic oral steroids and I come off of oral steroids 100%, that reduces my life complexity 100%. I mean, chronic oral steroids impacts their daily life. So reducing therapy, to me, when you control patients' disease on a biologic, is reducing complexity.
All right. This is one of those other benefits where we are going to wordsmith it in the next kind of iteration of our value framework, because the term triggers different responses when we think about complexity of administration, complexity of the patient's life. What are we talking about?
Right.
So we need to tease that out better. But here, this is generally meant to imply a difference in the administration mechanism and how that would lead. Because as we know, in a clinical trial, it may be that a complex regimen is done and all the patients get it, but in the real world, it might not turn out that way, whereas a pill or a self-administered injection could obviously have better real-world effects. Okay, I think we should go ahead and vote on, again, please vote for all of these that you think provide a significant other benefit, and if you've got some Fs, we can talk about that at the end. If not, just don't click on F. But please go ahead and vote now. And because the system doesn't kind of tell me when you're done, when it's this multiple voting approach, I'm just going to look at faces, and if I see faces looking up at me, it means you're done voting, and if I'm not seeing your face, I'm going to just wait for another few seconds. I think I've seen everybody's face except for one. Is anybody still working on it? I think, Greg, are you still working on it? Okay.
Almost there.
Nope, no pressure. Greg Kerfman, no pressure.
Cue the Jeopardy music.
Okay? Yes. All right. Now, it's a little challenging to read the way it's displayed this way, but as you can see, with a total number of voting panel members of 15, we have 3 for reduced complexity. We have 0 for health disparities, reducing health disparities. We have 6 for caregiver burden. We have 8 for novel mechanism of action or approach. We have 7 for impact on ability to work, and 3 Fs. And again, trying to do this quickly, but I want to capture those Fs for the record. Who thought there was an important other disadvantage or potential benefit that we should note? Tim?
Well, this is Grumpy Tim. I had to weigh in the fact that, as best I know, the majority of people in these studies had severe, not moderate asthma, and that the comment about reducing oral corticosteroids was important to me, but that defines people as severe, not moderate. And so the way I looked at it is that a large number of people with moderate asthma who are not on oral corticosteroids would get this, and I know of no clinical benefit in those individuals.
Okay, we'll make that kind of a note modulating the vote for at least some members. 2 other people, if you want, if it's, hopefully if it was important enough for you to put an F down, you'd like to let people know what it was? 2 other people? Maybe F was a wide finger when you were pressing E, we'll see. Don?
I heard loud and clear that there is a placebo effect from the injection. So whether that's non-clinical, I don't know, but I viewed it as such. I just felt that it seems as though qualitatively people feel better because they have a little better control of their life. So it's intangible, but can't put that into quantifiable terms.
Okay, I think we should probably capture that as an intangible benefit that might not have been captured by the quality of life instruments. I'm not sure we want to link it to the placebo effect because that would raise some other issues, I think. But okay, let's move on to the contextual issues, though, the last set of votes before we break briefly for the roundtable. So here again, we turn to a different kind of issue. These are not really other benefits per se, but they're putting the evidence in context in a variety of different ways. One of which, and I'll just read it quickly, but are any of the following contextual considerations, again, trying to send a signal to policymakers who will look at the evidence, look at the numbers, what's important in the context for people who are trying to judge the value of these treatments. And we're asking about dupilumab here in particular versus usual care without biologics. So, one issue that comes up is the context around the severity. Is this a treatment for care of individuals with a condition of particularly high severity? B is this intervention is intended for the care of individuals with a condition that represents a particularly high lifetime burden of illness. So some conditions can be very acutely serious, others have particularly high lifetime burdens of illness. C is this the first intervention to offer any improvement for patients with asthma? D, is there significant uncertainty about the long-term risk of serious side effects of this intervention versus usual care? E, is there significant uncertainty about the magnitude or durability of its long-term benefits? And F is, are there other additional contextual considerations not up there already that you think should be remembered by people? Anybody want to have a weigh in, Stuart?
So on the couple that talk about significant uncertainty.
Right.
The word significant is the one that I struggle with, especially since we made such a big point about long versus short and what really is long-term results from a biologic study. I think the agreement that was clear in the evidence was that it's not long-term, but the word significant is one I'd like to hear from the folks at the table. There's no signal here that made me worry that we're going to miss it during the long term. Is that how I should look at those two questions?
Doctor, you want to start? Do you understand what his question is? So let me just try to reframe it. I mean,
Okay, go ahead.
basically, we say significant uncertainty. You always ask versus what.
All right.
I'll just give you some context to the question about that context. So it could be that we're talking about a treatment with a brand new mechanism of action, and it has some biochemical features that we've not seen before. It drops your cholesterol to 0, and no one's ever seen that in a human before. So we might have real significant uncertainty about longer-term effects, either risks or benefits. Other treatments might trot down a more well-established pathway, either a similar mechanism of action, or we have nothing else going on in the body that we think of. Some clinicians and policymakers would say, gee, it doesn't matter. A brand new drug within the first couple of years, I'm always going to have significant uncertainty, and that's, to me, important. So there's no perfect definition of this. It just gives you a chance to convey in your mind whether there is significant uncertainty about dupilumab versus usual care that you think policymakers should weigh. I'm not sure if I stole your thunder.
No, it's a difficult question to respond because to me it is it's a little bit difficult to understand what the uncertainty is. Of course, we all have uncertainty about these biologics because they just got approved a few weeks ago, and they haven't been out in the wild, as we like to say in practice. So I can say is that the drug has been studied now in its program for I think over 6 to 7 years, almost 3,000 patients studied in the pivotal trials, and so that is reassuring. But all these are being enrolled in extension trials, so we know long-term safety. And as reported by some of our industry members, some are out to 3 years, some are out to almost 5 years now with long-term safety. At this point, we see no long-term signal there. The only thing that's very fascinating to me as a clinician taking care of this is I put this akin to our rheumatologic drugs that we've used for many years, where we did not understand how it was modifying the patient's disease process until we were able to follow the patients out for long term, right? And we found, yes, these drugs had a great impact on disease, the joint erosions and so on. And I think the same thing's going to happen here with asthma, that when we start to understand better what's happening long-term in these patients, I'm hoping, and again, this has not been studied, we're still in the midst of that, is that this will change the disease process and the remodeling that occurs in the airways so that our patients don't continue to have decline in lung function every year. And that's what our hope is for these biologics, but there's still uncertainty about that result.
Yeah. All right, let's go ahead. I'm going to go ahead and take the vote just because we have to move forward towards the policy roundtable. Sorry about that. So let's go ahead and vote again on all that might apply in terms of contextual considerations that are important in assessing long-term value for money. Okay, is anybody still working on it? Greg or others? No? Oh, Don's still working, okay. Okay. So, again, kind of hard to read from off my screen. So, A, high severity, 11 out of 15. Lifetime burden, high lifetime burden of illness, 12. First to offer any improvement for asthma, 0. uncertainty about long-term risks of side effects, 7, more uncertainty about long-term benefits, the magnitude thereof, 10, and 3 additional contextual considerations. So we can capture those again.
So one of mine is an F. So I've spent a good chunk of my career working on self-management behaviors and self-management practices, and I'm very excited to see a product come to market that puts the patient in control in many ways and is able to self-manage this condition. However, that comes with a possible trade-off on adherence, and if the adherence follows what we would expect to see in other self-managed treatment plans, there would be important additional contextual considerations that would affect my judgment of the value of this, given the price point and the possible waste of product that could exist in this case.
Okay.
So I'm kind of in the broad category of self-management. The benefits of it, great, but I don't think we don't have data to suggest outside of clinical trials that the adherence would be similar to what we see in the physician office administered.
Okay. Other significant contextual considerations that someone wanted to mention at this point, Don?
Well, it's really, it's not so much F, Steve, as it is just being clear when we talk about long-term that it's 2 years and no more than 5 years. That phrase long-term bothers me a bit, given the narrow time frame that we have to assess long-term risk. So I just put that down.
Okay. And Tim?
We talked a lot about some of the quality of life. I think getting at some of the issues about return to work, school, lost days could markedly alter some of those perspectives, anywhere from making it to really be a cost-effective approach if really there's a big impact there, especially for folks with moderate, where that's a big bulk of the patients where I'm concerned might be a slippery slope of this drug.
Okay, thanks. And before I wrap up this, I just got a note that I closed out the voting too quickly, so we should add one more vote to D and one more vote to E to people's final tallies that will be reflected in the report. Okay, so I'm just going to say, whoops, we have a break as the next slide. I heard a couple of distinctive other benefits, as we mentioned, for dupilumab versus the other 3 in terms of it being able to be self-administered. If there are other really important distinctive other benefits or contextual issues that you guys would like to try to bring up now between the different biologics, now is a good time. Again, it's kind of a footnote to the votes on value and other benefits that we've just taken. Is there anything distinctive between those drugs about other benefits that you think we need to highlight in addition to the self-administered versus doctor-administered? Okay. If there's not, there's just one last process issue before we go to the break, and that is that there is no vote on long-term value for money because the base case was well above the $175,000 per quality threshold. After consideration of the information and the conversation, the comments from manufacturers and others, does the council feel that there should be a vote because the base case is, in your minds, actually lower than $175,000? It should be meriting a long-term value for money vote. Seeing none, we will continue with that process and procedure, which means that we are ready to break. Now, the policy roundtable is where we invite up payers, manufacturers again. We'll continue to benefit from the clinical experts and the patient representative. We are going to launch into, in many ways, what feels like the dessert of today, which is to talk about what are we going to do in the real world with patients, doctors, coverage, pricing, future research, that kind of thing. We want to try to have as much time for that as possible, but I know people need at least a short break. So I'm going to say 10 minutes. If you can please try to be back in 5, it'll really help us kind of kick things off. I know that we've got arrangements for the manufacturers to sit at that table again. So thank you. We'll be back and start right at 2:40 p.m.